Perfect.
Okay. Okay. So thank you all for joining today. And as you can see, the title of my presentation is When Things Fall Apart and When They Come Together, tracing the processes of a task-shared intervention for perinatal mental health and depression in South Africa. So just a little bit of background. There are high levels of perinatal depression and other common mental disorders in low and middle income countries. And this has a significant burden of disease and negative impacts on the fetus and the infant. And risk factors for perinatal depression are particularly high in low and middle income countries, including South Africa. There's a significant treatment gap between those that require treatment and those that receive it in low and middle income countries to treat perinatal depression and other common mental disorders. So task sharing using non-specialist health workers to provide basic mental health services has been recommended as a cost-effective means to address this treatment gap and reduce the burden on mental health specialists in public health services. Evidence has shown moderate effects of task-shared treatments on the reduction of perinatal depression, but little is known about the actual processes, mechanisms, and elements that lead these treatments to be effective. So this study was nested in the AFFIRM randomized control trial, which tested a task-shared intervention using community health workers to provide six sessions of counseling to depressed pregnant women in Khayelitsha. The inclusion for participants were that they had to be 18 years of older, less than 28 weeks pregnant, screened 13 or above on the Edinburgh postnatal depression scale, and attending one of two MOUs in Khayelitsha that the study was situated in. The intervention arm comprised 6 sessions. The first was psychoeducation, then problem solving, behavioral activation, healthy thinking, birth preparation, and then termination and evaluation. The control arm received 3 standardized phone calls inquiring after participants' general health, but nothing more. And 425 women were recruited into the study. 97 of them completed all 6 sessions in the intervention arm, and 187 participants received all 3 control phone calls. And the locally adapted Hamilton Depression Rating Scale was used to assess the primary outcome of the intervention at 3 and 12 months postpartum. And just to say that we had 6 counselors who were employed on the study, and they were community health workers who had previously been working at an NGO in Khayelitsha, providing education on pregnancy and birth, but not psychological counseling. And we had 2 control community health workers who weren't trained in counseling. They were only trained in the control phone calls. So the AFFIRM results showed non-significant difference in response rate on the Hamilton Depression Rating Scale between the intervention and control arm at 3 and 12 months postpartum. However, there was a significant difference in the mean EPDS scores between groups at both 3 and 12 months postpartum. So this prompted the need for a process evaluation to be able to examine the intricacies of the counseling sessions, to investigate the actual processes of the therapeutic sessions, and go beyond examining whether it worked or not to examining how it worked or didn't work. So the study objectives were, before implementation of the RCT, to examine local pregnant women, mothers, and health workers' idioms of distress and understandings of the symptoms and perceived causes of perinatal depression in Khayelitsha, to inform development of the counseling intervention, and to provide contextual information for the intervention. Following implementation of the intervention, to examine the AFFIRM-SA counselling manual and explore potential influences it may have had on the RCT results, and to examine the processes that occurred in the implementation of the counselling sessions. Right, so for all the quantitative researchers out there, this was a very qualitative thesis, which I really enjoyed doing. The methods for the study involved three main methods. The first, for the first objective, was semi-structured interviews with 12 depressed and non-depressed pregnant women and mothers of young babies and 13 healthcare providers. And a framework analysis was employed where you come in to the data with a few pre-specified themes, but you are also able to let other themes and codes arise from the data. The second was the analysis of the counselling manual. And the third was an analysis of counselling session transcripts. So of the 97 participants who completed all 6 sessions in the intervention arm, 42 participants were randomly chosen across all 6 counsellors, and then 3 were excluded because of inadequate transcriptions. So this amounted to a total of 234 counselling session transcripts that were analysed. And a grounded theory approach was used to analyse the data. So just a note on grounded theory, it was very suitable for the purpose of the process evaluation. Because what you do is you read the transcripts with a very open mind, and you use what Strauss and Corbin call a constant comparison, where data starts to kind of speak for itself, and you start to pick up codes from the data that start to endorse each other, and that slowly builds up a narrative around what was going on. In this case, it was what was going on in the counselling sessions that really could not be demonstrated from the statistical analyses of the outcome measures. And so from this narrative, you slowly form what they term a grounded theory of what went on through the data that you've been analysing. So I really loved that process and found it really fascinating. And it was ideal because the nature of the process analysis was to kind of look at what did or didn't happen without coming in with any assumptions beforehand. So to my knowledge, this was the first large-scale study of processes and mechanisms occurring in actual counselling sessions across a number of counsellors and participants in a task-shared intervention in a low and middle-income country. So the formative research results for Objective 1 from the framework analysis found that women spoke of their symptoms and their idioms of depression using phrases such as withdrawal and not wanting to talk, crying or sadness, poor concentration, thinking too much, fear and anxiety, stress, sleep problems, headaches, and body pain. And these symptoms that women discussed were also compared with 2 international measures of depression, the DSM-5 and the ICD-10 scales. And we found that the experiences that women had of depression were similar to these international scales, but they used different words and idioms to describe them. So that was quite an interesting finding. And then women gave attributions or causes for the depressive symptoms that they were experiencing. And these included a lack of support, having an unwanted pregnancy, death of a loved one, poverty, unemployment, thinking too much, coping with a new baby, and stress. So moving on to the grounded theory results. The codes and themes that arose from the grounded theory could be categorized broadly into 2 main categories of processes that occurred in the sessions. And these were deviations in intended theory and protocol, and conversely, elements that were therapeutically effective in the sessions. So I've used the word deviations as quite a broad descriptor for things that didn't go according to plan or according to the theory that we had in the RCT or the actual protocol in the manual. And these deviations could be broken down in turn into two main themes. The first was therapeutic breakdowns in the session. So this obviously would relate to the interactions between the counselors and the participants, the women themselves. So examples of therapeutic breakdowns would be a misinterpretation of psychological concepts by the counselors, inadequate explanations of therapeutic activities or of the required homework, inappropriate reading from the manual, brushing over problems that participants identified or minimizing these problems, providing absolute assurances for these problems, providing advice, and reprimanding participants. And then secondly, it was very clear in almost every counseling session that women face persistent poverty in their lives. And this condition exists in a self-perpetuating cycle of other factors, such as food insecurity, intimate partner violence, economic abuse, alcohol abuse by partners, lack of support from partners, HIV/AIDS, and continuously occurring traumatic events. So this could also be referred to as persistent distress, where the woman experiences stress and distress throughout the counseling process, which interferes with the effectiveness of the counseling. And as you will notice, this links back to the formative research where women reported socioeconomic circumstances as their primary cause of their depression. So these two themes encompassing the deviations really help to understand some of what was happening in the sessions and help to provide partial explanations for why the RCT did not show significant results on the HDRS, the Hamilton. Now, moving on to the therapeutically effective elements. Despite the above deviations, women provided consistent reports of improvements in mood and depressive symptoms, as well as examples of improvement in communication, behavior, and cognition. And not only did they report feeling better, but they also provided accounts of reasons or elements that contributed to these improvements, which provided a great insight into the kind of therapeutic elements that were effective in these sessions and that may therefore be used as contextually appropriate strategies for future interventions. So these attributions that they mentioned were improving knowledge through receiving advice on relationships, pregnancy, birth, and on depression, which was psychoeducation, one of the sessions, a normalization of feelings of depression, the commitment from their therapist, the experience of confidentiality and trust, sharing problems, a sense of relief, empathy, and being heard, and experiencing a sense of connection and hope, and also the effect of the baseline assessment. So just to come back to the grounded theory to explain it again, or to talk about it again, it kind of worked in an opposite way of how it's been presented. And basically, reading through the data, I would pick up things like, for example, a sense of relief at having spoken to someone. So a woman would talk about the sense of relief that she felt now that she'd shared her problems. Or someone would say that, no, the baseline assessment really, really helped her to feel better when she met the field worker, which was not part of the counseling. But, and likewise, kind of, I have no food. That is what's causing me to feel depressed. And so these small codes were all, these small examples were all coded into smaller codes, which then were grouped together to form the themes, such as therapeutically effective elements or the influence of socioeconomic context on therapy. So the way it's presented is kind of backwards to the way it worked in reality. Okay, so having found the deviations and the therapeutic breakdowns in the sessions, and also the non-significant results on the HDRS, there were quite a lot of reasons that came up that may explain some of these deviations. And the first was a question of competency of community health workers, with the expectation that they, with minimal education levels, that they are able to conduct psychosocial counseling with limited training and supervision. And I think it's something we really need to think about in task sharing, because it's such a promising thing to reduce burden on psychological and psychiatric providers, but the low levels of education really may be a limiting factor in providing task sharing. So also in using and reading a manual, that could possibly lead to an interactional dilemma between counselors and their patients. And I know even I have struggled when I'm trying to talk to someone and also reading something at the same time. I think it can be an extremely difficult thing. So you know, manuals also have been put forward as a way to help counselors in task sharing. So just to follow a manual strictly and therefore also, I guess, in research, be able to then have fidelity to the intervention. However, if counsellors have to read too much, it really impacts on the therapeutic connection between participant and counsellor. And so I think that's something else that really has to be examined, is kind of how much reading should be done, or how much should be left to really basic counseling skills that the counselors could be taught. So as a result, I think that the counselors developed some coping strategies to merge the expectations of the research study with their abilities. And they also possibly didn't feel an ownership of the intervention. Because although formative research was conducted with community health workers and depressed women, it wasn't conducted with these community health workers having looked at the intervention itself. And I really believe that if they had been given the opportunity to provide feedback on the content of the intervention, this might really have assisted in making it more contextually relevant for both themselves and for the participants. So another possibility is that the intervention didn't sufficiently address the context and the socioeconomic need of the participants. And also, there may have been unrealistic expectations for the supervisor to not only clinically supervise the community health workers, but also be a cultural broker between the academic research expectations and the reality of the context that also women face in Khayelitsha and in the clinics on the ground. And lastly, there's a possibility that there were too many psychological modalities in the 6 sessions that the community health workers that the counsellors had to work with and use. Moving on to the therapeutically effective elements. What was really interesting about the elements and attributions that the participants identified was that they, almost all of them, have been put forward as common elements or common factors of therapy by other authors. So some of these previously identified common elements identified from other literature are warmth, empathy, collaboration, active listening, normalization, genuineness, trust, and rapport building, and you get the picture for the rest. 2 things that stood out that are more unique to this study was the positive role of advice, which women identified with, and I'll discuss that a bit more a little bit later. And then also, as I mentioned previously, that wasn't part of the counseling sessions, but many women spoke about the positive impact that the baseline assessment had on them. And for me, this just really gave pause for reflection about what the baseline assessment represented for them, which was a sense of connection. And often they would say that the field workers gave them hope. And I just think that it really can't be underestimated, the importance of connection and hope, especially in times like this when women are so isolated. Even though they live in kind of cheek by jowl in Khayelitsha, in townships, they really are isolated. And if they're feeling any level of depression, which is really stigmatized in these communities, just the experience of listening to someone, or having someone listening to you, really can be quite influential in their feelings of depression. So from the results, I developed two kind of models or theories of what might have gone on in the randomized control trial, in the intervention, that may have led to both the therapeutic breakdowns, but also the therapeutically effective elements. And so the first model is that the intervention did not disrupt the mechanisms that perpetuate depression. And so just to go through this model a little bit, and we start in the middle on the left and with identified needs. So what was rightly identified was that women were depressed using the screening tool, the EPDS screening tool. However, possibly if you go down, there were other missed needs such as economic skills and IPV strategies to try and reduce or prevent IPV. Moving on from depression in the middle, the theory was then to address depression through psychological and behavioral techniques, which has shown to be effective, particularly in Western situations and in other task shared interventions. But there's a possibility that this particular psychological theory, or theories in this case, using behavioral activation and problem solving and healthy thinking, may not have actually met the contextual need of the women and the counselors themselves. Moving along to design, the design was manualized, as I've mentioned, and used many psychological modalities. And in this regard, perhaps the manual was not helpful enough for counselors who had low levels of education. As demonstrated, there were therapeutic breakdowns and contextual influences that affected implementation of the psychological modalities. Moving to the actual implementation, that had 6 sessions of counseling using community health workers. There was also potentially suboptimal training and supervision for counselors, and maybe the format of the supervision needed to focus a lot more on actual competency in knowing, really grasping the psychological skills that were needed. I think, and reading up on other literature as well, there's often a tendency to discuss case studies in supervision and not go onto a deeper level of actually examining therapeutic competency, which also is really very important in the training process to begin with as well. So what the woman did receive at the bottom right is advice, connection, psychoeducation, normalization, trust, commitment, sharing problems, sense of relief, and a sense of being heard. However, if we go up, they did not all receive the intended psychological skills that were intended from the theory, any kind of economic skills, which they expressed a need for, and maybe some IPV strategies to help prevent or manage IPV in their relationships. And this kind of fed into a feedback loop, which speaks to the mechanisms that perpetuate depression, such as continued trauma, economic stress, and IPV within the situation and context of poverty, unwanted pregnancy, isolation, abuse, food insecurity, and HIV/AIDS. So that was kind of one of my thinkings of how the intention was so good, and the symptoms are there, that the depression is there and present. However, the context is so strong that perhaps behavioral and psychological techniques in this instance weren't able to match the need of depression. Okay, so moving on to the second model, which is kind of termed that the intervention provided connection and short-term resilience. So the second model suggests that against the highly stressed and traumatic contextual background in which the participants lived, the act of talking to a counselor, being heard, experiencing empathy may have provided a sense of connection, support, and ease of isolation that was able to act as a buffer to keep distresses at bay and provide a reprieve, although it was brief, of their everyday stress. But unfortunately, although the counseling sessions were obviously helpful to the participants during the sessions, these changes were probably of a temporary nature that existed because of and within the therapeutic time frame where the women felt that they had some form of support through the connection with the counselors. The sense of connection and support was short-term and therefore could not reduce clinical symptoms of depression or provide longer-term resilience against the context of extreme poverty, in part also explaining the non-significant results of the AFFIRM-SA RCT. So this diagram is just to kind of represent the buffer of resilience against the extreme trauma of poverty. And yet, unfortunately, it seemed to be short-term. So moving on to lessons and recommendations that we were able to extract from the grounded theory and from this study. Given the and these, I think what's important is, although this was an intervention for perinatal depression, I think that these lessons and recommendations really can be used across other interventions for other common mental disorders. So given the time and resources invested into randomized controlled trials, I personally think it should be an ethical obligation to investigate the mechanisms and processes behind the significant and non-significant outcomes in an intervention, to be able to share lessons and recommendations that can inform the development of future interventions. So the first recommendation is to conduct formative research that is participatory, so that you can receive feedback from counselors and participants alike, and make sure that it's more embedded and appropriate and integrated into the context and community. The second recommendation is, following formative research, to continue to conduct responsive research that allows an iterative approach to implementation, where the intervention may be shifted to better suit the needs of participants and counselors if it's required. I acknowledge this is very difficult in a situation of a randomized controlled trial where things are really very strictly controlled. However, I think that many kind of issues that might come up with an intervention that probably only counselors are able to identify, or even participants themselves, could and should be addressed during implementation. And this would really allow for a much more contextually appropriate intervention, and also one that kind of is probably more suited to how things work on the ground and to the actual needs of participants and counselors. So I feel like there must be a way, and implementation science is certainly one of those ways of doing this. If responsive research is not viable, then conducting piloting that assesses both the content of the intervention as well as the practicalities of the implementation would be very important. Then the next recommendation is to adopt a staged approach to diagnosing and treating depression. And Vikram Patel wrote about this in 2017. This would assist in, firstly, distinguishing between depressive symptoms and perinatal distress or normal distress, not related to pregnancy. And then after this has been done, to provide more appropriate strategies for those in different stages of distress to depression. So this would range across a spectrum, for example, from group social support, group economic support and skill building, to more individual psychological therapy for those who are more clinically depressed. And then obviously at the far end, referral to psychiatrists or psychiatric nurses for medication interventions. And so I'm going to take this point to just talk a little bit about the AFFIRM findings and outcomes, because the EPDS, Edinburgh Postnatal Depression Rating Scale, was used to recruit participants into the trial. And this screens for depression, but really is more a screening tool and kind of demonstrates distress rather than clinical depression. The HDRS, the Hamilton Rating Depression Scale, measures clinical depression, and it was this that was used as the primary outcome measure. So what happened was, women were recruited into the trial using the EPDS, and all of them were certainly distressed, but probably only about half of them were actually clinically depressed. And by the time 3 months after birth they were measured again, quite a lot of women improved in their situations of distress, and and then a lot were not clinically depressed anymore. And so just a note on trials that we would obviously need to use the same screening tool and to recruit in and then to measure primary outcome following this. And I think that the trial results did show that there were significant effects on the EPDS, and that we really can't ignore. I think it's quite important, and it really speaks to that sense of connection that women developed between their counsellors and themselves. Moving on, I've spoken a bit already about the importance of evaluating competency of community health workers, both before and during interventions. I think this is so important, and also would then empower community health workers so that they're not kind of left lost once an intervention has started. I think it's also important for us to know that we're working in a situation of power, particularly in the academic situation. So community health workers who are mostly Xhosa-speaking women are in a social cultural context of disempowerment already, and probably really don't feel that they can speak up to the higher powers of academia or their PIs or kind of possibly even their supervisors about what is working and what's not working. And so I think a kind of a continual evaluation of competency and then extensive training, even following the initial training, really would help to kind of pick up any problems along the way and assist in empowering women, empowering the counsellors themselves. And then also, it's very important to provide training and support for supervisors as well, and then include kind of assessments of content comprehension of the counsellors in the supervision strategies. So the next recommendation is to include common elements of therapy in the intervention themselves. And these common elements of therapy that have been mentioned previously should serve as the basis for all psychological treatments, regardless of modality. And as it has been shown, some researchers are now really putting forward that this really could be the basis of interventions themselves. And then you kind of going forward, you kind of may pick one therapeutic modality that you could use across all sessions, whether it be healthy thinking or whether it could be behavioral activation or problem solving. But the use of the subsequent use of a single therapeutic modality would also really help the counsellors to become a lot more familiar with how to use it, and not having to kind of skip from one strategy to the next. And also for the participants themselves, because I think sometimes psychological concepts are hard to grasp, and I think sometimes we can make assumptions because we're all really working in that field and make assumptions about how easy it is to understand these concepts. And I think it's pretty hard. So if these are continuously repeated over a number of sessions, I think that could be really very helpful for both counsellors and participants. And then something that is very close to my heart is that to add elements to mental health interventions that address some of the social determinants of mental health, such as economic skill building components or cash transfers, ways to address intimate partner violence. I really, just kind of, it just comes up so strongly, as I've demonstrated in the models, of how influential poverty and all the factors related to poverty are in mental health, and then in the implementation of interventions. And so these really need to be incorporated into interventions rather than kind of set against them and trying to work like in this context, but only using psychological techniques. A note about the manual. So I think the manual should either be extremely explicit with very, very kind of strict instructions guiding counsellors to follow every single step, or quite open with only a few key pointers, and then really relying on some of these common elements of therapy and a kind of well rehearsed therapeutic modality. So very important, process evaluations need to be conducted throughout an intervention, and feedback on these evaluations should become a requirement for trials, in order to increase the amount and flow of information around what works, why it works, within interventions, rather than simply whether an intervention worked or not. I think this is so important to share this information, and I think it could kind of springboard interventions going forward, because you know, it's all very well to report simply the results, but there's just so much that goes into the workings of conducting research, but also the actual implementation of counseling, that is really very, very valuable stuff. And importantly then, to the process evaluations and the mechanisms of change need to be reported, so that other interventions can learn from them, and also so that we don't assume cross-cultural transferability simply because a study shows significant effects. All right, so in conclusion, this thesis highlighted the importance of process evaluations in unpacking many elements and mechanisms that occurred in this psychosocial intervention for perinatal depression that otherwise would not have been examined. In addition, the use of grounded theory revealed many possible explanations behind the differing effect sizes on the HDRS and the EPDS as the primary outcome assessments. The study particularly highlighted the role of social determinants in influencing mental illness, where participants expressed that their depression symptoms were, to a large degree, attributed to the experience of social, economic, and environmental distress in their lives, and that an amelioration of these stresses would contribute significantly to their experiences of depression. It's also important to realize that task sharing is not a panacea for solving the mental health burden in low and middle income countries. In order for task sharing to be more contextually relevant, we need to conduct research and interventions that are more responsive to both the practical needs and the psychological needs of those with mental illnesses, possibly using a staged approach and finding ways to address some of the socioeconomic issues that are driving much of the psychological distress in low and middle income countries. So I just want to thank Margie Schneider and Quick Lund, who were my supervisors in this PhD, and who I certainly couldn't have done this work without. And very importantly, to all the field workers, participants, and counselors who really made this study possible. Thank you.
Oh, wow. Thanks so much, Thandi. I think this is probably one of the most in-depth explorations of task sharing and the pros and cons and some of the challenges that we are facing. There has been a number of questions. Let me just get the chat up again so I can go back to them. First one was by, here we go, Ashley. Talking about sort of group chats and support groups which are led by non-therapists, do they think that would be effective in the context of the work that you have been doing? So having not just individual interventions, but having more support groups, I suppose, for the women.
Yes. So something I don't think I will ever forget was right in the formative research when we were recruiting women, doing interviews with them, and we were speaking to a woman who was depressed, and she said, I actually wish I had HIV/AIDS because they have support groups that they can meet every week, but nobody talks about depression, and I really would love to have a support group. And I think this should be, I think you said, Ashley, you said it all, antenatal clinics. I would be there championing for this, because so much of the distress is just a lack of social support. And to be able to have a group situation where you can check in and find out that other women are going through similar problems, and kind of, and to be able to have it at the clinic is also really so important, because they'd be coming there anyway, and so they could just join a group. And I would really think that would be certainly extremely effective. And it's also very surprising and very horrifying how little knowledge women have about pregnancy and birth as well. So to not only be able to share psychological problems, but also just practical problems related to pregnancy and birth would be extremely helpful.
That could be less stigmatizing as well, as opposed to having sort of a group just for depression. It could be more integrated into a healthy lifestyle.
That's right. I know AFFIRM-SA recommends that, so that it's kind of phrased as information on or health information, but what they cover is also psychosocial issues.
Thanks, Thandi. I hope I haven't missed any other questions on the chat, but if we do have some time, if there's anybody else that would like to ask any questions for Thandi, please do speak up. I do have a few if no one else has any other questions. Anybody else? All right. So Thandi, maybe not. So my question is really about, I mean, as doing grounded theory and going through 234 transcripts, you know, with grounded theory, flexivity is very important. What kind of system, I know there's some qualitative researchers on the call, did you have any systems in place to ensure that? Oh, yeah.
To ensure what, Kat?
Keeping reflexivity and keeping your you know, everyone comes with these sort of biases for when it comes to research. And did you have any systems in place to ensure that?
I didn't have systems in place per se, but I was very aware of that, and also knowing that I had been working on the study as a research officer as well. So I had kind of a number of different hats in place. I think one thing was just keeping a constant awareness that that strategies used by counselors may not, and actually I don't think I really mentioned this in the talk, may not have actually been inappropriate for the women themselves. So as I was reading as a kind of Western orientated researcher trained in Western psychological methods, I would kind of read a strategy that the counselor had used and think, oh, this is really not appropriate. But it was so important for me to, and the data kind of backed it up, to see that actually women were appreciating it. So for instance, the huge amount of advice that the counselors provided the women was actually really appreciated, and they wanted it, they asked for it, they needed it, and to me it's that, you know, in modern counseling, well, Western counseling techniques, we absolutely say you shouldn't give advice. You should always elicit answers from participants. And I think that perhaps this is an important strategy, that it's a cultural technique, that advice is very important. And so I think that was the biggest thing I did, was to kind of really read it with an open mind, that just because I've been trained in a certain way, that doesn't mean that this is right and this is wrong, that it may actually be quite contextually appropriate in this situation.
Brilliant. Simpiwe, I see your hand is up.
Hi, Thandi. I hope you can hear me with the background noise. Can you guys hear me?
I can, yes, thank you.
Okay. Okay, I just wanted to find out, just with the context of the constant distress, or the bombardment with the socioeconomic factors, what is the expectation? So is there work that's done on resilience in that kind of situation? Is the expectation that despite that, they would be able to still overcome and not exhibit any signs of depression if they are receiving counseling? So I don't know if the question makes sense completely, but just when a woman in that situation is being counseled, is the expectation that they would be able to find coping strategies to be able to manage a situation like that, or in order to decrease their symptoms? Or yeah, what are we expecting from them when they are in a situation where they can't, and we can't fix their economic and social situation?
Thanks, Miriam. That really, I mean, sorry, Simpiwe, that really is the ultimate question, isn't it? And I think generally the hope for counseling is to improve resilience, so that women or participants are then able to face their traumatic situations or their situations of distress with a little bit more resilience and a little bit more ability to deal with whatever things that they're having to deal with. Obviously, I don't think that it's possible to solve these socioeconomic situations with psychotherapeutic means. But I think probably bottom line is to increase resilience. And another thing that came up from the study was an increased ability to communicate with where it was their partners or their friends and their counselors. And there's a big role of communication in increasing connection, and there's lots of research that shows the importance of social connections. So I think almost like a little step up in terms of being able to improve resilience, improve communication, hopefully connection with your neighbors, with your family again, which would enable a little bit more ability of the self to cope in these situations.
Great. Miriam has a question.
If I can unmute myself. Wow, thank you. Thank you so much for having this opportunity to share your work. As I've mentioned in the chat, this is some of the work we've done with community health workers as well, in terms of looking at capacity to deliver such kind of interventions in Khayelitsha, but in the field of diabetes management. And the techniques, in terms of the training, you said there were some issues, or you've had some challenges around training and then delivery and outcomes. What we found very useful, because we often found that there wasn't enough support in the literature, showed not enough support that the community health workers received during this process, or in helping them deliver the implementation, the intervention, so there was didactic training, which is important. But then also we looked at using motivational interviewing techniques, which we were quite surprised was picked up quite quickly by community health workers, and whether it was culturally just the way language is used in Xhosa, and so we found that quite useful. And I know that practice has been used more and more in family medicine research. And then my last point was, in terms of support, it was group-based interventions, and we used video support. And that seemed to help a lot. That went along with the manuals. It just seemed to give the community health workers that little bit boost and support in providing the I suppose in ways of being able to articulate messages or to guide them. So I can just share that, and would really at some point like to cross base, because mental health is such an important point to start any health, down one's line in the lifespan. So really found your work interesting. It's tacit knowledge, but to see it in the research and the work being done is fantastic. So thank you.
Thanks, Miriam. And those are very interesting comments. Thank you very much.
Great. Naima.
Okay, thanks so much, Thandi. Absolutely just such an interesting and I think really valuable presentation, particularly the context I'm coming from is, that we are actually looking at implementing, and Kat's been assisting us with putting together a manual for this. So almost implementing actually the ASPIRE and the ASSET, an amalgamation of those two interventions really. And specifically for students, senior students in the health sciences faculty. So medical students are almost task shifting actually to medical students, social work students, so social sciences as well, of course, OT, etc. And we sort of in the process of implementing a pilot study at 2 community health clinics. So this is really useful because, going into the beginning stages of this pilot and looking at your experience, sort of looking back, I think it's really helpful, just so many aspects. So there's just one thing I wanted to focus on, even though I have so many sort of questions and thoughts, but just the one particular thing was around the actual modality that was used. So if I remember correctly, from the ASPIRE sort of techniques that we used, it was mostly focused on problem-solving therapy, if I'm correct. And then I was wondering sort of if you had any sort of thoughts, ideas, just from even the transcript of how the participants actually responded to that particular, modality. Were they able to, for example, sort of implement, were there specific challenges that came up around that? And I'm also, of course, bearing in mind the fact that, as you've mentioned, the problems are so you know, kind of, yeah, widespread. I mean, these are contextual problems, not just one specific thing to work through in a problem-solving approach. So I just wondered if you had any thoughts about that, please.
Thanks, Naima. I think the biggest thing in the problem-solving therapy session was being able to share problems. So, well, being able to identify problems. And even the act of identifying problems was quite therapeutic, because it almost kind of puts thoughts into a coherent sentence or group or whatever, rather than just this constant thinking too much and rumination. And then working, and then I think they did appreciate working through with counselors what could possibly be solved and what couldn't realistically be solved. So, you know, like a sense of perspective on getting, and then the many times, and this is often where the advice came in from counselors, but many times the advice was to speak to someone or speak to your family, or, you know, like speak up and talk about a problem that may be solved. And women would often come back and say, I spoke to this person, it was really helpful. So I think in regards to problems that can be solved, I think women really did appreciate that opportunity to kind of bounce ideas or get assistance or get advice on the strategies that could do, because often they came in so disempowered. And as a lot of us know, like with depression, the thoughts are so ruminative that you can't see the wood for the trees. And so to be able to identify some of these problems and find some potential small solutions was actually very helpful.
I'm just, Thandi, one quick question. So with the 6-session AFFIRM intervention, it was a number of modalities. So was problem solving just one session as opposed to having a single modality of problem solving or CBT? So it's slightly different than the asset projects that's focused more on just that one modality of problem solving. Is that right?
Yeah, that is correct. Yeah.
Great. All right. Any other questions we're missing here in the chat? Just want to check. Great. I guess I have one more question, which I think always comes up when we talk about task sharing, is the needs of the counselors. So often they come from very difficult circumstances. They're struggling with their own problems in their own communities and families. What was in the supervision, was there support for that, or is there something that you would recommend going forward as part of supervision? You mentioned that they often do case studies in supervision. But when it comes to lay counselors and asking them to do quite a lot that they weren't necessarily willing to do it, they didn't go to sort of training for that per se. Would you think that would be quite important? Or what would you recommend?
Thanks for bringing that up, and that is certainly one of the recommendations that was in my thesis but didn't come into this presentation. And I think, interestingly, in our study, counselors were offered external psychological counseling, and only 1 or 2 of them took it up for only 1 or 2 sessions. So something else needs to be done, because they certainly did feel the strain of working with such extreme trauma all the time. And I think that could certainly be packed into counseling sessions, supervision sessions. But I think there's also like a pressure of so much to get through, and there's like this kind of tendency to focus on fidelity to manual, to the intervention, and as I said, checking case studies, that perhaps checking on the psychological state of counselors isn't top priority. So I think that would be important. I think maybe even in that case, a group therapy, but without the presence of the supervisor, but in a more culturally acceptable context. So still in Khayelitsha, with someone who's maybe more similar to the counselors themselves, where they would be able to feel that they could speak openly about their problems. That might be a good strategy. Yeah.
Great. All right. Do we have any last questions for Thandi? We have 4 minutes before our time is up. Let me just do a quick check. Any last hands? Oh, Claire?
Thandi, thanks. That was an amazing presentation. That's really fascinating work. And I really loved your model with the buffer against the traumatic stress and everything going on the outside, so some resilience. When it comes to the actual modalities, do you think, was there any one of the modalities used in AFFIRM that you think was particularly helpful for people experiencing high levels of traumatic stress?
It's quite hard to, thanks Claire, it's quite hard to tell, but I think probably problem solving. Because of what I mentioned in terms of it enabled a discussion of the problems. So it wasn't always used exactly as it was intended by the counselors, but I think the act of talking about problems really helped. So as it was, some of the women had said, like sharing my problems helped, and after sharing my problems, a sense of relief that I felt, and so being able to address some of these problems certainly is a product of problem solving therapy, but the act of talking about them and sharing their problems also was probably effective. They did often speak about I'm thinking better now, and we had the healthy thinking, kind of replacing negative thoughts strategy. But I think that was probably not as common as the problem solving. Thank you.
Thanks, Thandi.
All right. Any last questions? You seem to be doing well. Wonderful. Thanks, Thandi. As always, it's an amazing presentation, and I think the work that you've done is really going to advance the field. I mean, as you mentioned, there's a lot of just sort of RCTs. We're getting a lot of outcomes, but there's very little exploration into the in-depth issues as we all move into a task sharing approach. So thank you very much, and thank you all for coming to our first CPMH seminar of the year. I'm hoping that in the next 2 months we will be having another one. I think it's Vixen, who's also doing something similar. Emily, who is also doing some amazing work. Also, it was for her PhD on AFFIRM as well. So hopefully we have a bit of a theme for the next two seminars. And then finally, Vixen Asrat from Ethiopia, who's also doing task sharing intervention with HIV and HIV population in Ethiopia. So we have a bit of a theme this year. So we do hope to see you all at the next one. Thank you, everyone.
Thank you so much.